present and watching this to the first public board meeting of Manx Care. In future, we hope very much that these meetings will take place face-to-face and that members of the public will be able to attend them. But inevitably for this first meeting, we've had to make some compromises to balance the needs of public accountability against the constraints that coronavirus imposes on us. And of course, we had to plan this meeting some time ago, so we were not absolutely certain what the situation would be. So first of all, just to explain a few things about how today's meeting is going to work. People watching will have had access to the paper, so they'll be able to see the agenda, and we'll go through that item by item. I'm not going to go around the room now and ask everybody to introduce themselves, although I will introduce myself, and I'm Andrew Foster, Chairman of Manx Care, but people will introduce themselves when they speak for the first time. In order to see who is speaking, apart from it being the named person on the agenda, we have two systems. One is where people can put a virtual yellow hand up, which we'll try to monitor and bring people into the conversation when they indicate they want to do so. We also have a chat box for people to either answer points that are raised or ask if they can come into the conversation, and that's going to be monitored by Sarah Pinch, the Vice Chair, who will alert us to anything we need to see. It's a slightly clunky arrangement, but we will make the most of it for, as I say, these circumstances. The meeting is being filmed as you can see it, so if you can see the same thing as I can see, you can see about 14 faces on screen. I want to just point out that not every one of those faces is permanently pointing directly at the screen, and that's because we tend to have two screens open, one so that people can look at the meeting and the other so that they can look at the agenda papers. So if people are not always looking directly at the screen, that explains why that is. And then the final thing I want to say is that we have apologies from Kath Quilliam, who can't attend today and is being represented by Sue Wadiker. And we have apologies from Vanessa Walker, who is unfortunately unwell today. So unless anybody has anything they want to add to that, I shall move on. Okay. So the next item is a standing item, the declarations of interest. I would ask if anybody's got any additional interest they wish to declare other than what's on the printed document. Okay, and again, that will be every board meeting will have that set of declarations of interest which are there to be scrutinised. Now the next item, sorry, Anne Corkill, would you like to come in?
So Anne Corkill, HR Director. I just wanted to highlight that I think it's got Claire Coney's details, so I've replaced on this board, so you don't have my declaration yet, which would solely be government, say prospect membership, so union membership.
Thank you, Anne. Thank you for coming in on that. Okay. So the next item would have been the minutes of the last meeting, but as this is the first meeting, there are none. And the next item would have been the matters arising from that meeting. So again, on this occasion, there aren't any, but obviously there will be in future. Item 26 is about notification of any other items of business, and I have not received any notification. So we will be limited to the items you can see on the agenda today. So the first sort of substantive item then is one on the corporate risk register, and I'm going to invite John to introduce himself and to talk about that.
Thank you, Andrew. Yeah, my name's John Middleton, and I'm the board secretary for Manx Care. You no doubt will have had a chance to review the papers before the meeting, and if you're watching this as a member of the public, then they're available for download on the website. The papers explain the general principles of here, but really there are three documents which we're considering here. First of all, it's the corporate risk register, and those basically explain the matters which affect the three principal risks to Manx Care. or the things affecting the three principal priorities to Manx Care being improving patient safety, creating a positive work culture and improving financial health. And documents have been circulated, and it's a way of assessing the risks and assigning a status to those risks depending upon their impact. The second class of documents within there are the documents in relation to risk categorisation, and the principle of that is to ensure that there is a consistent method for recording risks across each of the care groups within Manx Care. And then thirdly is the board assurance framework. The idea of the board assurance framework is it's to provide a system and a set of controls to ensure that any risks identified and present on the corporate risk register are managed appropriately. It would record any assurances that we have over the controls implemented around those risks. It would itemise any gaps in controls, and it will record actions around those risks in order that the board can ensure them that they're being dealt with appropriately.
Okay, John, so in terms of this meeting, you're introducing this for the first time, but what would you expect to happen at a normal meeting? Would we be going through those risks one by one? What would happen?
Yeah, indeed. I mean, there's still some development work that's taking place here, and this was put with the audit committee yesterday. There will be a process whereby risks are fed from the care group up to the board, and there'll be an escalation policy for those risks to be escalated up and down from the board from the board to the individual committees. Those will be subject to review, and again, we will be looking each month at the steps that we are taking to manage those risks under the board assurance framework.
Thanks, John. Teresa, you have your hand up.
Thank you, Chair. Yes, it is just to identify that we have undertaken the first performance and accountability reviews with the first 4 care groups, and what that has identified is the need to systematically go through all of the risks on the care group risk register. So as John has highlighted, we do expect this baseline to change. I think there are a lot of risks that can now be mitigated, but we have set a deadline of the end of June for that work to be completed by all of the care groups, which would give us a much clearer position around the risks for Manx Care that are ultimately at a level that the board needs to be aware of by the end of June.
Thank you, Teresa. Katie, you have your hand up. Would you just introduce yourself as well, please?
Certainly, I'm Katie Kapanaros. I'm one of the non-exec directors. So just to pick up on John's point about the audit committee yesterday, we had a very good discussion about making sure that we linked the required outcomes and the objectives of the organisation with the risk register, not only with the inherent risks or the inherited risks, I beg your pardon, that have come into the new organisation, but also defining any new risks. So we had a very good discussion about linking that and the objectives and the required outcomes. So it all hangs together with the golden thread, which was a phrase we were trying to avoid, but that's where we got to, the golden thread.
Thank you, Katie. And appropriately, we have the chair of the audit committee. Andy, again, please introduce yourself.
I'm Andy Guy. I'm one of the non-exec directors. I just wanted to mention that part of that discussion, just to enlarge on what Katie said, was around equalisation of scoring across the organisation for risk, which I think it's a bit bumpy at the moment. I think happened before. We need to make sure that we get direct line of sight right across and up and down the organisation. And at some point, and sorry, just to say that the initial work on that is to be picked up by John Middleton and Ollie Radford, and that finally, at some point, we'll need to be setting a trigger point where those will automatically come up to board. I think that's correct. Thank you very much.
Thank you, Andy. Right, I see no other hands up, so I think we've probably covered that item, although I expect it to be a longer item at future board meetings. So moving on then, well, the next item we have is my report, which again, members of the public should have had access to as well. So this is updating on 2 main areas, the discussions that we have on a routine basis with ministers and elected members, and there has been a transitional arrangement for the taking over of Manx Care's responsibilities for answering certain types of questions to the public and ministers, with others being the responsibility now of the Department of Health and Social Care. So obviously this is a new arrangement which we're working our way through. The first time we produced guidance for this, it suggested that all questions would be answered within 20 days. And I think probably there was not sufficient stress on the word within 20 days. The actual expectation is that most questions will be answered much sooner than that. Indeed, some can be answered very quickly, and to enable that process to work even easier, we want to bring together the various existing parts of Manx Care that deal with public questions and complaints into a single patient liaison and advice service, which will be up and running before too long. And in that way, there will be a service that people can contact, which in most cases will give an immediate answer. And at that stage, we'll be able to revise our guidance to say the expectation is that from the liaison service, immediate answers, more simple questions, we would expect very quick answers, and that the 20 days is the absolute maximum. So that's the first issue we've been trying to resolve with the politicians. The second is that clearly a huge amount of work has gone into establishing Manx Care, much more than frankly I imagined was necessary. But when you look at all the legal requirements, the financial regulations, the transfer of responsibilities, there has had to be an enormous amount of work done, and there's a weekly meeting that oversees that. At the moment, we have now concluded almost all of the formal documentation that is that goes between the Department of Health and Manx Care. We are in the final throes of sorting out some shared service agreements with all the other main government departments. We have now got an understanding of the financial situation, which will come along later on in the agenda. There is an enormous amount of work to be done in the field of IT, which we'll no doubt be taking more reports on in due course. But this is not just the ultimate goal of digitising healthcare and having a single integrated Manx Care record. There is a lot of work to be done in the transition from DHSC to Manx Care, and there's a lot of work to be done just to maintain existing contracts that we have for IT systems. We will be held to account by DHSC for our performance against the mandate, which describes what Manx Care must do in each year, and there will be quarterly meetings to cover that, and we've been working out how those meetings will work. And then finally, there's a range of other issues with other agencies where we've been discussing the handover, so an awful lot of work in that area. And then the final point in my report is about as I've already said, that we now expect restrictions to be lifted on non-residents of the island so that we can have a fully public board meeting at the end of July. Okay, again, I will stop there. Does anybody have any questions on my report? Andy.
Thank you, Andrew. It was just simply, you mentioned PALS, and I feel that PALS might need a little more explanation because as Manx Care, we're charged with ensuring that all potential service users, patients, carers are consulted on service and delivery of service, irrespective of their situation. And so, for instance, hard to reach groups such as those who would be classified as homeless, for instance, in other jurisdictions. Will PALS cover all of that, or do we need extra belts and braces approaches as well?
I've got various people who've got their hands up, probably with the answer to that question. So we'll take John first.
Yeah, that's right. There's a consultation that's being started in the next few weeks by the DHSC into the complaints process on the more wider level, and those factors which Andy mentioned are being considered as part of that. So yeah, it's going to be across all of the care groups and not just the hospital, and that's something that's been worked on actively, in terms of the integration and the association with the proposed changes to the complaints regime.
Thank you, John. Teresa?
Thank you. And just to supplement that, I think Manx Care has recognised the need for the PALS function to be more encompassing and broader and more reflective of an integrated organisation. So we will use all the principles that exist with a normal PALS service, but ensure they are tailored to Manx Care. So we will probably call it something different. So a Manx Care liaison advice and service, making sure we have captured all the elements of an integrated organisation. And we have discussed this at the executive team and have set ourselves a deadline of the 1st of July to have this service functional. So quite tight timescales, but as everyone has identified, it's a real priority to Manx Care to have that service available to all of our patients, service users, their family and the broader population.
That's very helpful, Teresa. And just for the sake of people watching this, we will try to avoid acronyms. So apologies for using the word PALS, but it stands for Patient Advice and Liaison Service. But as Teresa has said, we will be identifying our own name for the one provided by Manx Care. Sally, next.
Hi, yeah, I'm Sally Shaw. I'm the Executive Director for Social Care, and I really welcomed Andrew's comment then about the hard to reach, and just want to give some reassurance that we will be working with groups to make sure that they're not easily ignored, because I think that's what the term should be rather than hard to reach.
Great point, Sally. Sri, and please introduce yourself.
Yeah, I'm Dr. Sri Andol. I'm the Medical Director for Manx Care. Chair, I just wanted to kind of reinforce what Teresa and you have said earlier. You spoke about the time limits, but I want to reassure the board that time limits are only a part of handling good complaint. The other things is getting it right, making sure that the complaints get the right focus and being open and accountable and acting fairly and proportionately, putting things right. Those will be, and seeking continuous improvement will be part of those good complaint handling. And I think we will be writing up a complaint policy as soon as things get in place, and so that actually it is visible and it can be accessed by everybody who actually handles the complaints and what we are planning to set things right. Thank you.
Excellent point, Sri. It's quality as well as speed, isn't it? Yep, absolutely right. Okay, there are no more hands up, so I'm going to pass over to Teresa now for the Chief Executive's report.
Thank you. And as usual, I will walk you through the horizon scan, which we prepare to supplement the Chief Executive report. Thank you. So we'll just bring that up on screen. So just to very quickly highlight that the month of May, the second month of Manx Care, I have been focusing along with executive colleagues on getting out and about in our services, having high visibility. I think that's a very strong commitment from all of the exec team to understand all of our service provision and be visible in our services. So I've been out to Learning Disability Services and to Southland's residential day services in the south of the island. Myself and the Medical Director and the Executive Director of Social Care visited our Children's Secure Unit, which is run in partnership with St Christopher's and the aftercare services, and then the contact centre, which is run by Family Action. So some good partnership arrangements in place there, and good to meet those teams who are delivering services on behalf of Manx Care. I also just need to recognise that we transferred the Kildare function into Manx Care from the 1st of May, and myself and the Executive Director of Nursing have met with all of the staff there, welcomed them into Manx Care, and we will be maintaining their strong connection to Manx Care. They will sit as part of the Executive Management Committee. Also important to note that we celebrated International Day of the Midwife and International Nurses Day with some really great comms, some very positive actions across Manx Care. And in terms of the work we're doing to establish the Manx Care governance framework, we have established all of the subcommittees of the Executive Management Committee, which met for the first time at the end of April, meets for the second time at the end of this week. And we held the 4 performance and accountability reviews with each of the care groups, which is a new process which has given them the opportunity to share their issues and concerns and their good practice with the executive, and for the executive to hold them to account and be really clear with each one of those new care groups what their objectives are. And I think those have gone very, very well. We have the second 4 of those next week. We are continuing to be really mindful of the commitments we have made and ensure that we are on track with delivering against the required outcomes framework and the requirements of the mandate. So a really important piece of work that has been happening during May, led by the wider executive team, particularly the Director of Operations, is to prepare specialty by specialty improvement plans and develop the case to improve our waiting list further, which has now been submitted to the DHSC for their consideration. There's some really positive news around the vaccination programme, which continues to progress really well. And obviously there are some significant border changes which come into force from next week, moving down to a different framework which allows more freedom of travel. And Manx Care have responded to that and are in the process of updating our COVID escalation plan, taking on board all of the modelling that has taken place, and working with the Cabinet Office and the DHSC in order to do that. I do try to keep up to date, and I think it's really important we take learning from other health and care systems, and the National Audit Office have recently published learning from COVID-19 across in the UK. I think there are some really key messages in that document around how we mustn't forget social care when we are thinking about our response to COVID and our escalation plans. You know, the Horizon scan does indicate there's some really good work going on in all of the care groups. I won't go into detail, but it's there for the board to understand what our 8 care groups are responding to. And finally, I would just like to welcome Anne Corkill to the board. Anne has taken over from Claire Coney as the Director of HR, so Anne will be our board representative initial period of 12 months. During that time, we are going to work with HR colleagues to review the sorts of functions and HR processes that Manx Care wish to see. So there is opportunity for us to shape how the HR function sits to best support Manx Care in its delivery. I will stop there, and I'm happy to take any questions on the Chief Executive report. Thank you.
Thank you, Teresa. Well, I just want to echo that welcome to Anne, who's joined our board now and is here for the first time. Anne, do you just want to turn your microphone on and say hello, introduce yourself and say what you've been doing for the last few years?
Okay, so hi, Anne Corkill. For those of you who don't know me very well, I've worked extensively with Alamein Government and HR for about 20 years now, worked with every department of government, but latterly with the former DHSC. So really interested in Manx Care and really looking forward to working with you, because I think I'm already starting to see changes in the way things are operating. And so, yes, I'm really looking forward to it.
Great. Well, welcome to Anne. Now, any questions for Teresa on her report? Okay, I don't see. Oh, yes, I do. Andy.
I'm sorry, I seem to have quite a few questions this morning. Right. The transfer of the education department, the 17 staff members from Kildare transferred over. Were they transferred with full budgets, and are we in the process of creating a proper plan and beginning an Horizon scan for courses along with all the other Horizon scans to make sure that planning for future courses meets Manx Care needs?
Teresa, are you going to take that one?
Yes, and I don't know whether, I don't want to put Sue on the spot, but Sue may also be able to supplement my answer. But yes, it did transfer across with the full budget. And so we have that assurance. Obviously, our new Director of Nursing arrives on the 1st of July, but Kildare does sit within the sponsorship of the Executive Director of Nursing. Yes, we are already looking at what courses we need to provide, and certainly there has been some recent changes to courses to allow increased provision of CBT and mental health training as part of the Kildare function. But it is part of the work plan, Andy, to ensure that it's mutually beneficial that Kildare is providing the courses which Manx Care needs in conjunction with the universities across. And that we also support them, and they feel part of our team, so they're able to respond to our changing needs, because obviously establishing new courses does take some lead-in time. And I think one of the key messages I took away from meeting the staff and the leadership team of Kildare is that they want to be involved much more at concept level and understand the needs of the organisation to enable them to respond as best they can to our changing needs as we build our workforce, look at succession planning and look at what educational needs we require across Manx Care services.
That's wonderful. Thank you very much, Teresa.
I think it's a really positive move, Andy, and I'm certainly very grateful we've got the opportunity to lead the Kildare function as part of Manx Care.
Excellent. Thank you.
Great. Sarah, you're next.
Thank you, Chair. I'm Sarah Pinch. I'm Chair of the People Committee and Non-Exec Director and Vice Chair of Manx Care. Teresa, I just wanted really to say how wonderful it is to see so many visits continuing. That was a real commitment that we made at a board, and it indeed links to one of our objectives around, well, it actually links to all three, doesn't it? But particularly the one around safe care and culture. And I think it's often we see in organisations a great flurry of activity at the beginning and then a tailing off. And I just really wanted to offer great support to those of you, well, all of the execs that are on island and those non-execs that are on island. And obviously, as Andrew said, we're all looking forward to coming at the end of July and continuing that real focus on making sure that we meet staff and patients and service users and hear directly from them and hear those voices back on the board. So thank you for continuing that, and I look forward to supporting that when I can.
Great, Sarah. Teresa, you want to come back?
Yeah, no, it's just to say, I mean, I guess all of the executives hold that very strong commitment, and I know I've seen it, we're monitoring it. We've had a great response. We're made incredibly welcome when we go out on visits. You can never supplement seeing our services firsthand and speaking to the staff in their own environments. And we have made regular commitments to maintain that. So linking in with established programmes and visiting on a really regular basis to keep that visibility. So, whenever we've scheduled a visit, we've supplemented that by scheduling a further visit in either 3 months or 6 months. So we have that regular cycle of going back and seeing these services and seeing how they're evolving and seeing how they're feeling to be part of Manx Care. So yes, it's probably the best part of the job. It's to be fair. So we're all getting out and about.
Great. Well, we look forward to joining that process as soon as possible. I don't see any other people wanting to ask questions about the Chief Executive's report. So we'll move on to the next item, which is the committee chair's report. Now, the board, in order to do its work properly, has set up 7 board subcommittees, and we've got 3 of them who are reporting their latest meetings here today. The first is the Quality, Safety and Engagement Committee, and unfortunately I've had to give Vanessa's apologies earlier on, so she's not here to give that report. So I'll just go through the main items on it, and then hopefully others will help me take any questions. So there are 4 substantive issues reported to the board in this report here. The first is about data, and one of the big issues that Manx Care faces is a lack of robust and validated data, and it's our early ambition is to raise the standard of that very quickly indeed, a process that Richard Wilde is leading on, and the committee discussed the lack of accurate and substantiated data at its first meeting, and asked for next time round for there to be a roadmap, which is, if you like, a timetable with action points and milestones on the way, showing how we'll move from where we are now with a number of separate manual systems being collected separately and put into a report, to something ultimately which will be much more automated, higher quality, and capable of benchmarking against similar data from health systems elsewhere. So that's the first item, is about data and wanting to really understand the key metrics of quality, like mortality, serious incidents, falls, and so on. The second is about risk management. Risk management is a discipline that Manx Care will be embracing. You've already had an item on the agenda about the board assurance framework, which is, if you like, is a top-down view of risk from the board, but that is matched by a bottom-up view of risk from every department in the organisation, and those come together in the form of a corporate risk register with the departmental risk registers, and the highest risks will be escalated to the board for discussion. But the Quality, Safety and Engagement Committee really highlighted that these processes were not yet mature, and have asked for the support of the Audit Committee in picking up this work. And indeed, there was a meeting of the Audit Committee only yesterday, which spent a lot of time, which we've already referred to, on discussing and refining the risk management process. Thirdly, there was the issue of a quality report, and we received a quality report at the committee, and the request was that the information, which was largely about hospital care, should be expanded to include primary care, adult social care, children's social care, and social care in general in future reports, so that it becomes a fully comprehensive quality report for the organisation. And then the final item to escalate was the falls report. So this was an update on a report that had been provided 2 years ago, showed how there's been many achievements in terms of limiting and reducing the number of falls, but really identifying that there are plans to produce an integrated frailty service, so not just dealing with falls that have happened inside hospital, but trying to prevent falls from happening both in hospital and in the community. And the Quality, Safety and Engagement Committee said that this was a topic on which it wanted to receive regular updates. So those are the 4 items discussed on that particular committee. Do members of the committee want to add anything to that, or does anybody want to ask any questions? Okay. Oh, yeah, 3.
Thank you, Chair, for that comprehensive report, but I was just going to kind of add a couple of things to that report. You mentioned about there are 3 items on there. The first thing is about building up resource and capabilities. Number 2 is about benchmarking, and number 3 is about the data that needs underpinning that benchmarking itself. So I think one thing, we have started the benchmarking process. We have actually approved through our various committees on mortality strategy. So we will be starting on measuring the mortality as it was, and that would be the key first step towards benchmarking. Of course, that is not everything. There are many more metrics that we need to pull through, and data would help us get to where we need to, but we are not waiting for the data to start before we actually start on this process of benchmarking. So there is already an agenda to start that process much earlier than other processes gets into action as it was. Yeah. That's all I was going to say to you, but the work is already begun. That's essentially I wanted to assure the board. Yes.
Thank you, Sri. Excellent. Right, should we move on to the next one, which is the People Committee? So, Sarah.
Thank you, Chair. It was a very good and respectful meeting. I think, like we are all discovering in our standing committees, there is some work to do on data and making sure we have the right data to be able to provide or to receive the correct assurance and then provide that to the board. I'll take the report as read. I just wanted to highlight 2 additional items, which were a commitment from the People Committee to hear a staff story each month, and we did indeed hear our first staff story at the committee, which is really important and speaks to my previous point about continuing to make sure that we hear directly from our staff and hear their experiences. And we were able to, ahead of the board meeting, congratulate Anne on her appointment, and also thank Claire Coney for all her hard work in supporting Manx Care to date. So I think there are a number of issues that are in the report. I won't repeat them here, but I'm very happy to take any questions.
Thank you, Sarah. I don't see any hands waving, so it looks like the report is self-explanatory. So we'll move on to the third one, which is the Finance, Performance and Commissioning Committee. So welcome for the first time to Nigel.
Well, thank you, Andrew. Good morning, everybody. For those of you who don't know me, I'm Nigel Wood. I'm a non-executive director of Manx Care, and I chair the Finance and Performance Commissioning Subcommittee of the board. So we held our second meeting of the Finance and Commissioning Committee last week, a lively meeting, as you might imagine. I wanted to give you some context around the Finance and Performance Committee, because there is a one-page report in the pack which deals with some red items and also deals with some green items. But I think each one is worthy of a little contextual explanation. Our first meeting at Finance was really all about structure and content, because how many of us have spent hours and hours and hours looking at information that somebody has produced, but actually that information is not useful or it is not properly read. So we wanted to make sure that we had the structure and the content of the Finance Committee right. We had the right people there at the right time, giving the right information. So we spent a lot of time doing that at the first meeting. And at the second meeting, we moved on to this acronym called IPR, or Integrated Performance Reporting. And we looked at how we would actually capture KPIs, or key performance indicators, that would actually be meaningful and actually could be dealt with at the Finance Committee to give us heads up on issues that needed either looking at more closely or escalating up into the board or treating very seriously. Because clearly money and our money performance is very important to Manx Care. It's a key central plank of Sir Jonathan Michael's report, and it's a key item of interest to our stakeholders, the Manx people, government and the DHSC. So, we wanted to make sure that we got that right. So we had a lot of discussion around developing that metrics, and we decided that we would form a working group which would be across the piece, across the committees, to essentially report back to us in June as to the right KPIs that we would consider. Risk management is the second item, and risk management is clearly very important from a number of perspectives, but it often will have a monetary effect. So we wanted to make sure that we could take, if you like, a risk register that we'd inherited from the department at the outset of Manx Care, and look at that and review every item in that risk management matrix for efficacy, and also to intertwine with both the audit committee and the main board and the work that John has been doing on the risk outcomes framework. And clearly we're going to report back on that. But I want to emphasize that that is not siloed. It's actually capping across the piece, and there's good communication there as well. The latest forecast and management accounts, again, as any good accountant will tell you, the opening position is key. And, in an organisation as massive as Manx Care, this is a super tanker of an organisation. So, we were inheriting a position from the department and from Treasury, and we wanted to make sure that those items that were in discussion, or that perhaps had been talked about but not implemented, or perhaps had been implemented but not talked about, or those items that had effectively been promised but not budgeted for, were clearly analysed. So there's a lot of work going on around that formal baseline position as to what is our starting point and what does our budget actually start from. That is going to report back to us in June, and I'm very excited about establishing that. Compliance on contracts is a big subject because it will be no secret to you or to our listeners this morning that Manx Care actually buys in a lot of services from many different providers. Some of them are enormous, such as the National Health Service in the UK. Some of them are smaller and still large, such as our alliance partnerships with Northwestern Healthcare Trusts, Clatterbridge, to name a few. And so we are looking at each one of those contracts, prioritizing ones in terms of size and in terms of scale, and looking at them to make sure that they comply with all the financial rules that we've been set. This too is a great commercial opportunity for looking at where we can possibly make these, the way in which we buy services in, more efficient. And I'm sure there's more to come in the agenda as we go forward. That's a very exciting piece of work, I think, and a very important part of where we'll be delving into detail in the Finance and Commissioning Subcommittee. On the items of assurance, we have an item called the SIP programme. And I'm sorry, but I thought a SIP was a self-invested pension plan. But a SIP is not a self-invested pension plan. In health terms, it's a cost improvement plan. There is a clear gateway. We have a group of experts engaged on seeking to identify areas where we can find cost improvements. And I'm very pleased about that, and we will be receiving more reports in June on how that is progressing to look at where we might actually make cost savings going forward. But I think one thing I did want to explain is that there was quite a lot of discussion at the committee about looking at SIP, or Cost Improvement Plan as it's called, and actually changing the name. I think if we look at things in pure cost terms, it sounds very aggressive. I mean, cost is important, clearly, but what we rather focused on was quality and value for money. So we were looking at opportunities where we can perhaps save costs, but redeploy that money into something more effective more quickly. So there is a general desire that we actually come up with a different name to SIP, from Cost Improvement Plan to perhaps Quality Improvement Plan, or perhaps Value Added Improvement Plan. And that's something that I wanted to bring to your attention. And then the last item, budget setting for 22-23, time waits for no man. So already we are engaging on looking at what 22-23 budget is going to look like. So we're ranging ahead onto the horizon and looking forward to the next year. And I'm very pleased with the way that process is going. And indeed, we're going to receive reports back in August on that. So thank you, Andrew. If there's any questions, I'd be pleased to take them.
Thank you, Nigel. Excellent comprehensive report. And I think you've underlined the danger of acronyms in the NHS with SIP. And if anybody cares to Google SIP, you'll see that there are hundreds of things that SIP stands for, ranging from colour inkjet printer to cheeseburger in paradise. But what we were referring to here was the cost improvement programme. But in any event, we're going to find our own name for it. But as I say, a comprehensive report there. Nigel, Oliver, you want to come in?
Thanks very much. My name's Oliver Radford. I'm the Director of Operations for Manx Care. Just wanted to just provide a bit more context to to Nigel's first point around the working group around data. So as part of our mandate performance reporting through to the DHSC, we're required to report quite a significant number of metrics to them in order to assure our performance against the mandate. So what we've decided to do is, rather than create a whole industry out of it, is actually to use the mandate performance framework as our main performance framework for the whole of Manx Care. So we've arranged on the 10th of June to have a performance management workshop with all the relevant care group managers and heads of commissioning to actually work out, plus Richard's team from the BI team, to work out how we're going to collect this information. As I say, what we don't want to be doing is for people to be spending hours and hours every month manually collecting data. We want all of it to be as automated as possible, and also to be as useful as possible for each individual care group and service line to use it as part of their performance management framework. So hopefully by the next finance performance and commissioning committee, we'll have an update following that.
Very helpful, Oliver, and I think slides us neatly into the next item on the agenda, which is the integrated performance dashboard. So back to you, Teresa.
Thank you, Chair. And the integrated performance report is work in progress. I think that's fair to say. And we have highlighted through this board and through everybody else's reports the concerns we have around data completeness and data quality. So it is within that context that we discuss the integrated performance report. This is something Manx Care committed to as an integrated organisation. It is important we triangulate and look across all of the indicators and see them as a single report and understand the codependencies of the various services and what the performance metrics are telling us. But coming back to the point around visibility, and going out to services, that sort of triangle of actually seeing services for yourself, speaking to staff, is a very strong requirement at the moment, given we don't necessarily have the quality of data in order to look objectively at some of those service areas. This integrated performance report does cover for the period of March, so just prior to Manx Care starting. And I will just pull out a few key themes, because I think it's important to note that during March we were in circuit break. So we were operating under full COVID regulations, working to the COVID escalation plan, which does mean that a number of activities were stepped down. There was reduced footfall through the hospital. A lot of planned surgery was cancelled in order to respond to COVID. And so it is, I think, it really important to set that context as we have now come through the end of May. It's important to remember where we were in March. So just to pull out a few key highlights from the integrated performance report, and executive colleagues may want to supplement that. But the emergency department during COVID becomes our main admission route, and I think that's really important. We stop the direct pathways in order so we can ensure the COVID pathways are adhered to and we can screen and assess patients appropriately. So ED becomes the single front door for the organisation for admissions. Performance was 74% against the 95% standard. The department does struggle in terms of responding to the number of patients, and is a relatively small department considering the footfall. We do have plans in place, as the ROF identifies, to establish a same-day emergency care ambulatory function, which will ease the congestion. We're also looking at estates capital work in order to reconfigure the ED. There are things we are doing also internally to aid flow through the hospital. So the Executive Management Committee on Friday will receive an updated version of the escalation processes and a full capacity protocol for Nobles Hospital. As I said, a number of planned activities were stepped down during March, which is reflected in both theatre utilisation and also the number of cases taking place. One of the key priorities, again, for Manx Care during Q1 is to establish the policy frameworks to govern our waiting lists, to provide the assurance that our waiting lists are all clinically prioritised, and that we have appropriate clinical and administrative validation strategies in place to ensure our patient treatment lists and our waiting lists are clean and accurate. The performance around our cancer services has been a concern, particularly the breast 2-week wait pathway. So this is a triple assessment approach whereby the surgical and imaging teams all form a one-stop clinic. There isn't great resilience in that service in terms of these are single professionals. So we have, for example, one breast radiologist. We only have a couple of breast radiographers. We only have one breast surgeon. And so resilience in that service is impacted when we have circuit breaks, when we have staff absence, and there is high demand into that service. The 2-week wait standard hasn't been achieved in March in breast services, and as a result of that, additional clinics have been scheduled during May, providing additional 20 slots. The Director of Operations has worked with the team to put a plan in place to put in additional clinic slots for the next few months. Our longer term, more sustainable plan is we've approved the funding for an additional breast radiologist and are training additional breast radiographers, and looking at a more sustainable plan around surgical provision. All of that is linked back to our strategic partnership arrangements with the Northwest, with UK trusts, which will provide that greater resilience. So I'm confident we have a clear plan going forward for having a resilient breast cancer service. However, we do need to manage the interim and to get our waiting times back down to 2 weeks. So we have an improvement trajectory in place, which is monitored by the executive team. I'm pleased to report that diagnostic performance is continuing to improve. So some improving performance against the 6-week standard we have set ourselves in the required outcomes framework, and reporting turnaround times in imaging are very good. I think it's also worth notifying the board as to how well the pathology service again has responded during COVID, with very, very high numbers of bobbing taking place during March, but some excellent turnaround times, and the service extended its hours of operating in order to respond to that. I think that's all I would want to really pull out from the integrated performance report. I will ask any executive colleagues if there's anything they would particularly want to supplement from my report. But I think it is really important to identify that it remains work in progress and something the executive team is prioritising in ensuring the board has the right integrated performance management report with a level of data quality which we can take good assurance from.
Thanks, Teresa. It's a 50-page report, so I think it's really helpful that you've given us that sort of digest of the key points and the key metrics. And I think, you know, we will be looking at issues like waiting times and the measures of quality as being the ones that we attend to most. I've got 2 people with their hands up. So first of all, Katie.
Thank you, Chair. So, Teresa, thank you for the report. It's very interesting what you were saying about theatre utilisation, because it's obvious in the graphs that there's been a dip. So if I could make 2 remarks. Firstly, is it possible, and I don't sit on the quality committee, so I apologise, but is it possible that we can have a year's worth of data so we can be a little bit more cognizant of trends, seasonal and improvements and that sort of thing? So a year would be really useful rather than just the calendar year or the financial year. That would be one thing. But the second thing is, could you just confirm to me what the denominator is for theatre utilisation? Is it a 40-hour surgeon's week? Is it how has that worked out?
So the maximum denominator for theatre sessions available is essentially it's 42 theatre sessions per week. That includes sort of the NC pod, that's the National Confidential Inquiry around patient outcomes, which dictates what emergency theatre provision should look like, and also trauma work. You know, I think, again, Katie, it's something we need to work on, because whilst that's the maximum sort of theatre capacity we have available, it will be dictated on a week-to-week basis by anaesthetic availability, surgeon availability, whether there's any scheduled maintenance going on. And I think we have to be much more accurate around capturing those exceptions. But when I come to the theatre report later on in the agenda, the second part of that piece of work is really getting into the nuts and bolts of how we look at theatre productivity and efficiency, and providing some assurance around how we report that, and then how we get to achieving good levels of theatre efficiency. But yes, the denominator is that sort of 42 lists per week, which is sort of the maximum we would have available to us.
Thank you.
Thanks. And I mean, just to add to that, this is why this report needs to be developed, is because, you know, 60% or 70% doesn't really tell you much on its own unless you're comparing it to the past or to comparable performance elsewhere. And of course, in terms of theatre occupancy, the situation has changed dramatically because of coronavirus. The amount of time that you have to take between each patient has substantially increased, therefore apparently reducing theatre productivity, but doing so for the right reasons, to improve quality. But that's why there is the ambition to continuously improve this and all other reports, so that what we're seeing is something that is really a true measure of how we are doing and how we should be doing. Jackie, you're next.
Thanks, Andrew. So I'm Jackie Lawless, I'm the Finance Director. So I just wanted to make a comment on the report as it stands at the moment. You'll notice that there's no financial data included in March's IPR, and I just wanted to explain the reasoning behind that. So at the instigation of Manx Care, a new care group structure was created, and the integrated performance report reflects that care group structure. However, the financial reporting as at March was still under the old DHSC reporting structure. So it was decided it would be more useful to exclude it and provide it separately, which we've done later on in the meeting. However, from April onwards, each one of those areas will have financial data incorporated into it, so we've got a fuller picture. And obviously there'll be commentary around the care groups as well. On that, and we're working with the BI team to make sure what we have is right, it's shown correctly, and again, as we've said before, it'll be a work in progress in terms of what we want to see, baselines and comparisons. So I just wanted to make that point as to why you won't see financial data for March in the report, but you will from April onwards.
Yeah, very important point, Jackie, thank you. Nigel, is it the same point or different?
No, it's a different point, Andrew. Thank you very much, and through you. Yeah, it's a slightly subjective point, really, from me on Teresa's report, for which many thanks. I think it's incredibly important, and it's a constant theme in an organisation that is dealing inevitably with change. And has had its very genesis from a robust report over the situation that we preside over, that we actually take a moment to celebrate the excellence. And I was really pleased to hear Teresa talk about, you know, how amazing the pathology department has performed, and it's just a general comment that we've heard in the listing events as well. In that, you know, people are run by organisations are run by people, and things happen by people at the Culfront. And I think when we're dealing with all of this nitty-gritty and changes and difficult situations, it's very important to celebrate the sheer excellence that is going on in parts of our organisation as well. And I just wanted to make that point.
Very good point, Nigel. Sri, over to you.
Yeah, sorry. Thank you, Chair. I just wanted to kind of say a couple of things here. The first bit is about, in no particular order, but first thing is about the theatre utilisation itself. Theatre utilisation is quite a complex efficiency marker, as we all know, and what we have already got a theatre improvement plan which is in progress at the moment, and that is to not just, we are expecting that program will not only lead to improved clinical standards but also improved financial performance on that. And we are looking at what we can do about the planned hours of sessions used, what we can do the actual runtime of sessions used as a percentage of the planned hours. And also we want to use about the patient hours as a percentage of use sessions. So this is all a kind of marker of improved quality as it is. So I think the data utilization improvement plan, which we have got underway, will give us better results as we go forward. The second bit I was going to talk about is right at the front door. We all know that A&E performance or ED performance is used as a marker for activity, or how well the hospital or acute trust is doing across the world. And we have got urgent and emergency transformation program, which is underway. And this is not just to identify, because front door performance of an acute hospital is not just about what happens within the hospital, but it is outside the hospital as well. So we are very keen that there is a system-wide improvement across how the patients are being looked after for their urgent care and urgent and emergency care. So that is a part of a bigger program as well. So two things in summary: we have got a theatre improvement plan. We also got an urgent and emergency care transformation program running in parallel that will help to improve both the clinical standards as well as financial performance. Thank you.
Thank you, Sri. I mean, it really is good to explain how the figures alone do not tell all the story. Even if they were completely reliable, you have to understand the context as well. And I think that's a journey that we'll take this organisation, take this board through to get ever more sophisticated understanding. Andy.
Thank you, Andrew. And I can see that there are some departments and areas that have shown great strength and resilience, and that's really, really good. But I couldn't let but the things that people use every day are not so much the hospital. They're the primary care functions: GPs, dentists, optometrists, and I couldn't let what I believe is a lack of adequate dental service provision and inadequate performance in dentistry, which is clearly demonstrated in the reports around about page 51, and I'm not quite sure what we have in place to try and improve this. So hopefully somebody can help me. But the sheer number of patients waiting isn't really very good, and some of the service which is being shown amongst dentistry equally I don't think is up to scratch. And if we're an integrated care organisation, this is quite a significant part of our integrated process. So if someone can help and explain what's happening with dentistry, I'd be really grateful.
Thanks. I mean, Andy, I'll bring Teresa back in a moment, but just by way of background, during most of COVID, dentistry had to stop. Well, not most of it, that's an exaggeration, but during some of it, it had to stop, and therefore you inevitably get an increase in waiting lists. Now, recovering that is a massive challenge throughout the world, and not necessarily an indication of poor performance by the dentists themselves. But Teresa, do you want to come in on that one?
Yeah, I probably don't have a huge amount to add, other than to, yes, absolutely, that I think there has been a sort of a deterioration in performance, and it is and remains a difficult to recruit to area. I think it's one of those areas, and I can see Oliver nodding, and he might want to come in also. I think it's one of those areas where we need to do a little bit more of a deep dive and understand what's going on, and it might be something which we've got the performance and accountability review for those services next week. So we definitely, as an executive, are picking that up and exploring that further to understand the reasons why, and probably happy to provide a little bit more information on that, perhaps into the Performance and Finance and Commissioning Committee next month, to sort of explain what our initial deep dive and assessment has identified. Andy, if that's okay.
Oliver, I see you got your hand up. Can you add to this?
I wasn't going to specifically talk about dentistry. My point was about something else, but just to add in about dentistry, I think the data that's in this report highlights the deficits that we have around our NHS funded dental services. So that's both dentists employed by ourselves, Manx Care, and also dentists that are commissioned by Manx Care to deliver NHS funded activity. And again, there's significant deficits in both of those areas of service delivery. So, but as Teresa said, that's something that we can cover when the primary care service come and present their performance and accountability review. But
okay, before you go on to your separate point, Andy, you've still got your hand up. Did you want to come back on that?
Oh, sorry, no, I didn't. I was listening carefully, and I agree that I agree with Teresa's point that obviously during the COVID pandemic, I understand performance would have been eroded, but I think most island residents would be aware of the fact that this is a persistent problem. I think Oliver has just alluded to that, and basically I think it is something we will need to focus on fairly soon, because it is a critical critical everyday function for an integrated care organisation. And that's, I just wanted to bring it to everyone's attention that it's easy to focus on the hospital, it's easy to focus on the bigger ticket items, but this is rumbling along the background. It's shared between NHS dentistry and with private dentistry, that basically where Manx Care will pay them for some of their activity, but it just doesn't seem to be functioning terribly well, I don't think. And that was really all I wanted to point out at this point. I'd like to see some improvement here, if possible.
Excellent and very appropriate challenge, Andy. Anyway, I'm going to go back to Oliver now, because you are going to make a separate point.
The only point that I was going to make is that the integrated performance report actually has got some key metrics in there, which will just shows where there is room for improvement around our efficiency, which will help improve our access. So, for example, the section around our DNA rate, so the number of appointments that people don't turn up to, is around 10%. So about 10% of our appointments are the patient doesn't turn up. So that is reflective of about 5,000 appointments a year within our new appointment. So that is obviously something that we can work on. Similarly, the theatre utilisation data, as we can say, at best we're running at about 60% of our theatre utilisation, and I know we'll move on to the theatre report a bit later, but actually driving that utilisation up to 85-90% will obviously increase our capacity for our electives and help us to reduce our overall waiting lists. So actually our access issues that Teresa has outlined, both on our outpatients and our inpatient services, actually we can make much bigger efforts to actually reduce the inefficiencies within the organisation and help reduce waiting times on both outpatient and inpatient services. So that's just what I wanted to say.
Thank you, Oliver. Jackie.
Thank you. I think it was really helpful, Teresa. Thank you to have that, as we said, the digest of what's in that report, because it is enormous. And I guess the comment I wanted to make was that obviously a lot of this information will be reviewed at a very operational level within the organisation, where those individual care groups, or even below that, individual functions, will go through this stuff in detail. And that's rightly so. And part of that, and that'll be picked up at the performance and accountability reviews. But I think from a board perspective, what I feel would be useful was if perhaps as part of the development of this report, we could start to assign status, like a red, amber, green status or something or whatever, so that we could just pull out and have a digest of the key issues that the board needed to focus its energies on, rather than having to troll through enormous amounts of data, because it's very easy to miss something. And again, unless you know the service or you have a context, it can be difficult to understand what the data is telling you. So I appreciate that it's not a simple ask, but I think it's probably something we should aim for, so that as a board we can really get clear visibility on where we need to focus our energies. Thanks.
Definitely, Jackie, and the same applies to the finance report as well, of course, but you'll help us through that later on. Anyway, back to Teresa.
Yeah, so myself, actually, the Director of Ops, and the Chief Information Officer did actually meet yesterday, and we have agreed how we will lift out and present differently some of the key indicators which are particularly pertinent to the board. And the indicators which are particularly relevant to the board are those which are aligned to our required outcomes framework. And as I say, there is a lot of information in this report which is entirely relevant to the care groups, but not necessarily that relevant to the board. So we've done that piece of work. We will start reporting, historic data. So we sort of have a 12-month trend, and if we can, apply some statistical process control against that, and also some RAG rating, both in terms of the performance. But I think it's important we start to understand where we've got good data quality, so we have a degree of confidence around the data presenting. So I'm used to working with a RAG system, RAG rated system, which is applied to data quality. So you know if your data is RAG rated green, you can rely on it. Where you've got less confidence, you RAG rate it amber or red accordingly. But that's the shift, and that's what we intend to present to the next board, is that more refined, more focused, so we really can be sure we are looking at the right indicators and giving them due scrutiny and attention.
Okay, and I think that's been a very clear theme across the first part of this board meeting about recognising the need, first of all, to improve the quality of the data, and then to improve its presentation, and then to improve our intelligent understanding of, what is good. So what is green, what is amber, and what is red. Okay, I think we've run out of hands up. We're running about 10 minutes early, so can I suggest that we take the coffee break now and come back in 10 minutes time at 20 past to resume. Okay, thanks everybody, see you in 10 minutes. Right, well, it's 20 past. I think we've got everybody back in the room as far as I can see. So let's move on with the agenda now. Just introducing the next item, what we've heard already is a lot of discussion about data, statistics and figures. And whilst it's important for the board to look at those, what we also recognise is that behind every one of those statistics are a series of people stories. So to bring that home to the board, what we want to do as a routine is to tell at least one of those stories every month. So pleased to say that we're going to kick off with our medical director. Sri, please take us on.
Right, thank you, Chair. And before the start of it, and I think I re-emphasize again, I think here at Manx Care, I think we would like to bring the patients, or any decisions we make at our level, we want to make sure that the patient is at center of that decision making. Now, so I was just going to talk about the context of why I'm talking about this story. We had a very difficult last year. Just to put it across UK, we missed about 1 million people have missed the cancer screening process. And the diagnosis of cancer, as we know, is quite a complex, it's a multi-step process. And unfortunately, there are missed opportunities that happen during the process, and there are chances that we do miss treating the cancers in a timely way. And if we look at why we miss cancers in a healthcare setting, it can be because of several steps in the diagnostic process, one of which would include diagnostic assessment. The part of it could be interpretation of the diagnosis itself, and also about the coordination and follow-up of the diagnostic pathways. And that happens both from the patient, the doctor care team, and also at the healthcare system. So thinking of those, I was going to give you a story of a patient who we missed diagnosing cancer in a timely way. I somehow don't like to call this as a story because it is a history. It is a real thing. It is not just a story. It is a history of a patient. Now, we had a 73-year-old lady who presented to this organization in April 2015 with symptoms in the right breast, went on to have some investigations, which included the mammogram, which showed what we call as a benign microcalcification, which is essentially meaning non-cancerous. And patient was reassured following that investigation and was sent home. Fast forward 2018, she was referred again to the clinic, breast clinic, with this time same symptoms, but also lump in the breast. She went on to have several investigations, one of which included the biopsy, and that confirmed that the patient has had a cancer. She went on to have mastectomy, which is removing the lump, and went on to have radiotherapy and hormone treatment as a part of cancer treatment. I'm glad to report that she tolerated the treatment well. She is recovered from the treatment and she is currently doing well. Now, the story or the history has highlighted, or it highlights several factors involved in missed opportunities for cancer diagnosis, especially in symptomatic patients. And we want to, at Manx Care, want to set up the basis and the foundation for developing a kind of a multi-faceted strategy to achieve timely diagnosis in the greatest number of patients. To that effect, we have started on, or we are going to be started from the 1st of July, a results acknowledgement policy, which is about electronically looking at the results of the patients in the computer and acknowledging them. And the objective is to remove any paper trail of the results, which are prone to be misplaced and being lost in the system. And as you know, paper results are not kind of completely validated as well. We want to use this as, this is not the entire story. This won't cover everything, but it will likely to motivate other disciplines, the multidisciplinary approach of our team approaching or taking several other steps to minimize this occurring again. We at the executive team under the leadership of Teresa has also done a lot of work we've already heard earlier about how we are responding to the waiting times in cancer diagnosis for the breast, increasing both the resource, the capability and the capacity along with the quality assurance. We are starting Clatterbridge at Nobles would be one thing. We also have approved the use of additional breast radiologists. We are training more radiographers to undergo training for breast radiology, and also implementing the results of the breast screening audit. And that will be forming a basis for improving the quality and assurance across the breast cancer screening. And to finish off with the story with the history, when I started off talking about this patient, following that process, we looked back at all the other patients during that period who have had cancers. To be precise, we looked at 1,220 cases of patients, and we called 36 of them back to our clinics, and they had appropriate treatment and investigated as necessary. So thank you so much for kind of listening to this, and we like to think that we have put the steps in process at the moment, at least one step to bridge the gap of identifying cancers in a timely way and reacting to that in the timely fashion as well. Thank you.
Sri, could I just ask you one question first of all?
Please.
You've explained there about this particular individual patient who had 2 episodes.
All right.
How clear is it that the cancer could have been detected earlier or should have been detected earlier?
Yeah, there are several reasons why we missed the cancer early. Because one such reason is that the radiology itself, if we do not, it is prone to misinterpretation. And in 2015, there were different way of looking at the radiology screening compared to what we are doing now. And that is what the better training and the training that has been invested in it. So it is about also doing the right appropriate investigations at the right time. So it is a mixture of factors, not one single thing, I'm afraid. But to your question, specific question as to if you are actually asking me that the 2015 cancer, was it the same cancer that's come now in 2018? The answer is not 100% yes and no, I'm afraid. It could well be a different cancer, but that is very difficult to ascertain. It's one of those vague things. It's it's a very abstract science. It is a difficult one to kind of say it with certainty.
Okay, thanks, Sri. Teresa, you want to go in?
Yeah, and thank you, Shri, for telling that patient story. I think I just want to sort of supplement what Shri's said is, in terms of, we are also strengthening our relationship with the QA programs, and I think that is our ability to ensure, we have got the right level of double reading, we have got the right level of auditing, and we are linked to established QA programs, and we've just put an action plan in place which is going to be monitored by the executive team. And I think this does sort of come back to us strengthening our relationships. There is a lot of breast cancer charities on Ireland who have an awful lot of great contribution to make in this space, and very active members with the ability to really help us transform those services even further. I think the hospital and Manx Care has benefited from that previously and will continue to do so. But also developing our strategic partnerships in the Northwest, and the Clatterbridge at Nobles is a very important part of that. And just finally, because we know there are issues both here and across the world and in the UK about how cancer has been impacted by COVID, and how we are dealing with some late presentations and some some different disease staging as a result of delayed presentation. So it is important we respond, it's important we build the right capacity, but it's important we also have the right pathways. So in conjunction with our transformation partner, we have initiated a piece of work which will be a tumour site by tumour site review of the clinical pathway, the diagnostics which sit around that pathway, the capacity and demand associated with that. So going forward, Manx Care can be assured that it understands the capacity it needs, both in terms of outpatient consultant-led capacity, diagnostic capacity, and then onward treatment capacity, whether that's either on island or off island, to sustainably deliver those pathways and achieve both the 2-week wait standard, but also the 28-day faster diagnostic standard, which I think is really, really important. It's an important pledge we need to make to the Manx Care public that your cancer care here on island will be as good as what there is in the best of anywhere else who are delivering cancer services.
Excellent point, Teresa. And I mean, that really is one of the biggest issues in healthcare at the moment, the impact that coronavirus has had on other disease areas. John.
It's a question about the processes under the new policy, really. So what you're saying, Sri, just if I can just clarify my understanding, is that when there's a diagnostic result received, that will be communicated to the consultant electronically, and it will be able to be tracked that that particular consultant has acknowledged that report. So that should reduce the situation whereby previously these things may have been done on paper, and perhaps there's opportunities to whatever reason for those not to be recorded. So we've got a fully closed system whereby we can make sure that, that there's not a loss of any paper records. Is that correct?
That is absolutely right, John. I couldn't have said it better. And this is, again, aligned closely to the digital strategy, which Richard might be able to explain it better. But this is one such process. It is about getting in line with with Manx Care for future, not just for the patient's old needs, but for future needs. Thank you.
Right. Katie?
Thank you, Chair. So, Sri and Teresa, have we given any consideration to the use of, and I don't mean this now necessarily, but the use of AI in reading initial diagnostics, and to, obviously there's still a secondary aspect to that, but it does have a very quick and sort of quite a high percentage rate of good readings to help us. So our AI is artificial intelligence, for those who are unaware. So there is the ability for a computer to a high degree of certainty to read an X-ray and say, yes, we need to look at that, or no, we don't. And there's always a second pair of eyes. It's never just left to a computer, but it does help speed things up. So I wondered if there was any possibility of us doing that.
So yes, I completely agree, Katie, and certainly AI, artificial intelligence, is particularly developed in breast imaging because it is about that pattern recognition, and it is particularly well utilised and evidence-based in the review of mammograms. Interestingly, it's only an initial discussion, but this is one of the key areas that I discussed with our breast cancer charities as to whether that's something they would want to engage in and support us doing some work on that. I think it's incredibly exciting. I think we need to look at those solutions, but whilst also sort of remaining very focused on the fundamentals. But it's absolutely something that I'm keen we get some exploratory conversations progressed and look at the opportunities it could present to us in terms of that sort of sustainable clinical model. So absolutely, we'll take that away as well.
Okay, and last word to Sri.
Yeah. Katie, thank you so much. Just a couple of questions. And you talked about AI. It's a different story altogether. I think Richard might be able to articulate it better than I would ever do that. But I will say I'm a stroke consultant myself. And we are talking about AI that is not we're talking in distant ether. We already diagnosed a lot of vascular pathologies through AI at the moment. CT scans of the head are diagnosed with AI at the moment. So I don't see that this is not going to be very distant. This is going to be the reality. That is a solution both for accuracy, but also a solution for workforce itself and how we're going to be doing it. So I think it is going to be reality very soon, whether we like it or not. Thank you.
Okay, right. I think that's covered that item. So thank you for that report, Sri. So we'll now move back to one of our favourite topics of today, theatres. First of all, we've got a procedural issue, and then we've got a more substantive one. So, John, do you want to just cover the ratification issue?
Yes, yeah, thank you, Andrew. Yeah, it's very, very simple and short matter, really. It's just for good governance and record keeping, really. As all of the voting board members will know, we circulated on the 23rd of April the requirement to approve the theatre utilisation project under the financial regulations of Manx Care, and it's really just to note and to confirm at this point that we're ratifying that proposal, which was unanimously confirmed in any case by all the voting directors in writing. So it's just for the record, just to agree that ratification. So I suppose it's just a case of just proposing that and recording the consent or otherwise.
Okay, I see no shaking heads. I see the odd nodding head, and we did decide this last time, so I think we can now formally record that. Thank you. Right, the more substantive issue then is the theatres update. So back to Teresa.
Thank you, Chair. And the board will be aware that as part of Manx Care preparing its baseline assessment, we reviewed a number of previous reports that had been undertaken by the DHSC. And what we identified was that there had been a previous external report undertaken regarding theatres at Noble Hospital by a company at the time called KM&T. That report identified some concerns around safety culture within theatres, and certainly there was some opportunities to improve both theatre efficiency and theatre safety. We discussed this with the Department of Health and Social Care, who were very supportive of us re-engaging with that piece of work as part of the Manx Care going live. And with the support of Treasury, and thank you to Jackie for all her work on this, we have been approved to implement that work, re-pick it back up in conjunction with the company that did the initial piece of work, who are now called Develop Consulting. So we have re-engaged with Develop Consulting and put in a programme of work to do two stages of work in our theatres. One, to look at ensuring our theatres are running at optimum safety, and we have the right team culture to achieve good safety in theatres, and then move on to a piece of work which will focus on achieving optimal efficiency in our theatres. So Develop Consulting started with us on the ground on the 26th of April. So they are sort of 4 weeks into that programme now. They are looking, as I say, as a priority at sort of safety and culture first, but then moving on to the processes, the standard operating procedures that we need to have in place, and then on to theatre efficiency. So there is just a very brief highlight report as I say, the initials in the report are those people, so we haven't named them, which is why they are initialed in the exception report. We did get a bit of an issue around being able to bring the external consultants on island through the exemption process, which did mean that having spent an initial period on island doing some of their initial work, they had to then go back to the UK. But we've managed to get around that. So they will be on island for the remainder of their work with us. We are getting a weekly update on this work through the executive team every week, and I will continue to bring monthly updates to the board. But the initial work, as I say, is making sure our theatres are using best practice in terms of policies, standard operating procedures, looking at compliance with the WHO, World Health Organization checklist, and making sure our theatres are running safely. So happy to take any questions on the report, but I think it's a really good example of us responding to a previous external report, working in conjunction with DHSE and Treasury to put in the solutions and getting that work started, which will be hopefully a very good sense of assurance for the board.
Thanks, Teresa. Katie, you're ready to go.
Thank you. Just very quickly, Teresa, can you draw a very basic parallel between the work, the outcomes, and how they connect to the required outcomes framework? So which of the required outcomes are we going to improve because of this?
Yeah, so I think certainly the first part of that work, Katie, is very much linked to our focus on patient safety. So first and foremost, we want to make sure our patients are safe, and that within theatres we've got a really healthy staff working culture. Teamwork is so incredibly important in theatres, and actually when you think about the implementation of the WHO checklist, the Band 2 support worker has equal say and equal rights to the consultant in terms of determining if they feel safe and feel ready to proceed with an operation. And that's the culture you want to create. And that's hard to achieve. Having done it several times before, that everybody is a key member of the team, and it doesn't matter what grade you are in theatres, everyone has a contribution to make and everyone needs to feel safe. Moving on from that, this definitely does respond to our requirements to reduce our waiting times and deliver our elective plan. I am concerned about our cancellation rates in theatres, and I want to ensure that we have good theatre utilisation. It also will respond to our CIP plan. So, I think it absolutely hits a number of our key commitments that we've made in our ROF around waiting time reductions, improving patient safety, improving culture, and being able to commit to delivering an elective plan and a CIP programme. So I feel this is an incredibly important piece of work for us to land, and I think I'm sure the board will want to stay very tightly focused on this as we go through the next couple of months as the work progresses.
So I guess the sort of the natural consequence of that, Teresa, is that we'll be looking for an update before too long. What sort of period of time do you think it would be sensible for the board to take its next update?
I would suggest, Andrew, given the pace of work on this, I would suggest we bring it back next time.
Okay, fine.
I'm happy to incorporate it into the chief exec reports if that helps. But yep. But I do think because of the pace at which we're seeing the work progress, a monthly update would be appropriate for the next two months at least.
Okay, well, I think we can agree to that. So that's very helpful. Thanks. Right, I don't see any other questions about that. So can we move on to the next item? So we have a guest to the board, David Siegel, who is the project lead for the Primary Care at Scale strategy. And David, you're just going to take us through an update on that with the key themes to seek any questions or comments from the board. So over to you, David.
Perfect. Thank you, Andrew. And hello, everyone, and thank you so much for having me. So, as Andrew says, today we've brought a paper around the primary care at scale strategy. So for those that haven't been directly involved in the project, and I know many on the call have, Primary Care at Scale is a project within the transformation programme that's specifically looking at one of the recommendations that talks to the need to have primary care working more collaboratively so that we can deliver current services in primary care and indeed future innovative services in primary care. And is very much focused on bringing together all the different aspects of primary care to work alongside Manx Care to do so. The Primary Care at Scale strategy is a culmination of a long piece of co-design work with the system, having engaged professionals from across previously the department and now obviously many of them Manx Care contracted organisations and their clinical staff and residents. So a fairly large engagement piece with residents that had a survey that 750 people responded to and a number of resident focus groups to essentially co-design what we think the future strategy for delivering that recommendation should be. Now, it's probably important to say at this point that the strategy is very much a living document, and we intend for it to be so over the next 11 months until April 2022, because we know the system is in a significant amount of flux in a good way, and there'll be a number of innovative things that we come up with in the wider parts of the system. It's really important that the primary care at scale strategy continues to link into those. But it is also important that we bring it to this group here today, as well as the transformation board, which we'll be doing later on in the month, just to ensure that there's visibility of the things that have come out of those conversations and that co-design period, and to make sure that we have a clear baseline to work towards. So clearly we want to start progressing some of the key elements within that, and have already started to do so, having taken some of those things through government procedures previously. But this really reflects a complete draft of a strategy that will give us a really clear sense of direction as a primary care system, and indeed a wider system that it locks into in terms of where we want to go with the work that we're doing. And the strategy itself has sort of two key elements that it tries to describe. So one is around the model of care, so how we'll support patients differently in primary care and how they will experience the health and care service in primary care. And the second is then how we reorganise the primary care system to develop that collaboration, to shift the culture in terms of how we want to support people more preventatively and in a way that joins up care. And so, although it doesn't specify the changes that we might want to particular clinical services necessarily, or clinical pathways, and clearly that sits somewhere else as a whole system activity, it does suggest how patients will be able to access care differently, be supported closer to home, and a number of different outcomes that I'm sure members around the table will recognise as important, but really consolidates what we're targeting and trying to do in primary care to deliver on that. And clearly there'll be a set of enablers in there that are also described around things like workforce, digital, etc. And again, it tends to be solution agnostic in some of those areas, but really defines the outcomes that we need to achieve in those different areas to deliver a more innovative, modern and continually improving primary care service. That's probably a good summary at that point, and appreciate the document's a fairly long document. We hope the executive summary is not so much of an arduous thing to read, but really wanted to pause at that point to give people around the table an option to ask questions or indeed test anything that I've just said.
Okay, well, David, I'll go first. I mean, as you say, it is a long and complex document, and it's quite conceptual in the way it's presented, inevitably being a strategy. Could you try to sort of imagine for me that we're 2 years down the line, this is well on the way to being implemented, and from a patient's point of view, what will the world be different? How will it seem different to patients, and how will they benefit from it?
A very good question. Clearly, fundamentally, what the strategy needs to try to be doing. So I think there's two aspects to this. One is we want to completely shift the way in which we think about health and care needs within primary care. And so where we have previously had a fairly contractual model that has, by pure pragmatism, had to borrow from England's contractual services quite often, and is clearly based on theoretical need and the services that might meet that, the strategy proposes quickly moving to a population health management approach, developing a much better understanding of the need that exists within the system and how that changes over time, and having the tools and information for clinicians to come round the table together to think about the specific need on the Isle of Man and to redesign services to meet that. So clearly that's still a process and that residents won't see, but what we hope to therefore see is that improvements on the island to health and care services will become more continuous, will be able to react more dynamically to the changing need on the island. And so where patients see a problem, we hope that that approach will identify as quick as the patients do, and we'll be able to adapt services to meet that. So that's the sort of more conceptual approach point, but we'll have a genuine impact and start having an impact on patients as soon as we get at least the first stages of that rolling. The second piece is we are already looking at some of the outcomes and how we can deliver services to better meet patient need. So one clear outcome within the primary care strategy is around delivering care closer to home, and that's looking at those service needs, clinical needs that are currently delivered outside of primary care that we think we can deliver much closer to where people live and where people experience their health and care services normally. So we are looking to move forward with some dermatology work, which brings specialist dermatology skills into primary care clinics. We're also looking at recruitment of wider allied health professionals to deliver first contact physiotherapy, mental health services, and pharmacy services. And we're also working with some of our community contractors in both pharmacy, optometry, and general practice and pharmacy to think about how they can deliver a broader set of services. So the strategy provides a very clear link between those outcomes to some of the ways you can achieve those outcomes, and we're starting to do some of the delivery work that will actually change how patients receive services and introducing new clinical capabilities within primary care, that people can essentially receive care within their GP surgeries or other areas closer to their homes that aren't at Nobles or other secondary care settings.
And again, just to take that example of dermatology then, so what you're saying is that currently people have to wait for an outpatient appointment at the hospital to see a consultant. Now they will go to a GP surgery and see somebody there. So are you saying that that will be quicker, more convenient, just in terms of pure patient benefit? Just explain that.
Yeah, so I guess all of those and above. So I think with the hub and spoke model, which is the model that we're using for dermatology, and we think is potentially a very good model for a lot of other specialist services. Previously, someone would have had to have seen their GP for a skin condition. Clearly, if it is a very serious skin condition, then they would have been referred probably through the rapid referral process into secondary care. But actually, the vast majority of these conditions that are currently seen by the skin service are not urgent, and that clearly has a waiting time because of the restricted level of capability that you will always have in specialist secondary care services. What we are doing is both developing GP skills and experience in dermatology through a targeted training program that will run over the next year to train up for GPs to run a fairly limited amount of clinics within their locality, and so we're targeting a 4-locality model in particular in dermatology, but will mean that rather than going to see a GP first, who may or may not be able to provide some advice, who will then refer them into secondary care, actually we believe there's a vast number of these cases where they will be able to see the GP with extended roles, who will have extended experience and skills. And actually that first appointment that they see people on, which would normally be a general appointment that then requires a referral, will actually be able to provide advice and treat the skin issue that they see. And clearly there will be some that still need to go see a secondary care specialist, but that connection between the experienced GP and the secondary care team, who will be working together constantly, and indeed clearly the training is being delivered by the skin service, builds up those relationships and provides a much better connection for them as well. So they will be able to feed in and provide much more joined up care in that sense. So we're hoping it will reduce the number of appointments patients have to see. They will be able to see the GP clinics much quicker than the secondary care. It will provide a much more joined up care pathway for when they do require further care at secondary care. And it also provides that resilience for the system, because we're increasing the number of people on the island that can see and treat some of these more specialist clinical symptoms.
Thank you, David. Right, over to Andy first.
Thanks, David. This is quite a complicated area. I just wanted to pick up on a couple of things if I could. So in your supporting detail, you say implementation of a population health management approach. I take it that is what the Manx government through DHSC published, which is basically people taking responsibility for their own health as an underlying approach. So that effectively it's, if you like, it's take care of yourself first, and then only, you know, so that basically we use services perhaps a little bit less. Is that what you mean? And also, isn't part of that strategy, that's part of the DHSC role rather than the Manx Care role, I think, isn't it? Because that isn't that strategy to nudge people, if you like.
So that is certainly part of it, and clearly the sort of responsibility of the DHSC to define the outcomes and that sort of shift of how we care for people is very relevant and feeds into this. But I think population health management is a more specific idea that essentially says we will use an evidence-based approach to understand the need of our population much better, and then meet that need with the limited resources that clearly we will always have, so that the right people are receiving the right care at the right time. So population health management will indeed identify those people that sit at the lower tier of a care pyramid, as often it's described, who can manage their care on their own, will get much better outcomes by doing so, will remain independent for longer. But actually population health management will identify all of the other areas of need as well. And so it's about being more specific about how we target the real need that sits on the island, so that the function itself is as simple or as complicated as collecting as much data as we can about patients to understand their need, allowing clinicians to see and understand that data as well, and for them to be able to target the resources they have at the patients that most need it. So within that population health management tool, whatever that may be, and they can be as simple as an Excel spreadsheet initially to as complicated as clearly very detailed data machines, that will also identify things like clinical specialisms. So diabetes is an area that's very successfully shown the benefits of population health management to identify the full range of needs that you can have if you have diabetes, from the much lower end self-manageable symptoms to the much more complex diabetes symptoms. But without that sort of approach and tool, you sometimes end up managing all diabetes patients in a very similar way, which clearly doesn't reflect their personal needs, doesn't maximise the benefit for them, and often creates a big strain on the health system in terms of how you can respond to the growing levels of demand and need that we have through the realities of population growth and older people.
Thank you. Andrew, one question, please.
Yeah.
Under the implications section of this document, you've got strategic aims, culture, and so on. Under equality, diversity, inclusion, you have not applicable. Is that just simply that basically that's not realised at this particular moment in time? Because obviously inclusion is obviously something that Manx Care is strongly focused on.
Yeah, that's exactly it. And clearly inclusion is an important part of some of the outcomes that we've expressed, and clearly equity of outcomes and equality of access are all important outcomes that are recognised in the framework. It talks to an important point that I know I've spoken to Andrew about as well, around the importance of moving from this strategy to a plan and moving to more specific solutions. And although there is a high level plan within here, what this strategy doesn't say is exactly what we're going to do, and therefore it's very difficult to say what our exact impact is on equality, diversity and inclusion. There will be some, and we very much aim and will prosper to it being a positive impact on those three key criteria. But at the level that the strategy sits, we don't know what the impact will be, and we'll need to do much more detailed assessments of that as we agree the sort of detailed solutions, business cases and plans that will come after this strategy. And we have done that for some of the more specific things like the dermatology work. We have thought about that in its specific context.
Okay, that's great. Thank you very much. I won't take up any more of your time.
Okay, Sri next.
Yeah. Thank you, Chair. I was just going to say, I'm not going to summarize the things, but I think your question about the fact is what will happen to the patient in 2 years from now? How is it going to be different for primary scale? I think it's quite poignant to think through what it is. For me, as a medical director for Manx Care, the reason why we support this of primary care at scale is because the patient will be considered in a more holistic way. That is the key bit. So a patient who's going to go to one place, one entry will actually be, the care they receive will be seamless and timely across both health and social care. And that would be the point number one. Number two, about Andy's question about, how the public health kind of agenda sits in with this. You're absolutely right, Andy. I think over the last couple of years or a year and a half, there has been nothing else in the public health apart from COVID. I think there's lots of collaborative working that needs to happen between general practice and the healthcare teams. We need to bring the other things in the public health care system that will strategized into dealing with clinical strategy that will align with the public health strategy with the Manx Care itself. So there is a lot of work that needs to be done. This is absolutely, there is amazing, there's a huge amount of work to be done, and there are lots of gaps in the whole system. So 2 years may be too soon to talk about it. Maybe it may be lots of work in progress, but that is what we will aim to do. Thank you.
Great, Sri. Teresa.
Thank you, Chair. And the executive team have had the opportunity to review this document as well last week with David. Thank you very much, and thank you to Anne-Marie also, who's joined us. I think the points from me is absolutely to confirm that this does need to be an iterative and co-produced document, as David's identified. We will continue to refine this. But we must do that in a really co-produced way with our key stakeholders. I guess in terms of the next iteration, what I'd be keen to see articulated more clearly in the strategy going forward is that clear link with our integrated wellbeing hubs and how that all sits together in those locality-based hubs. And I've probably just stolen Oliver's point. How we look at pharmacy, having met with all of the community pharmacists a couple of weeks ago on an evening session, they clearly feel like they can make a huge contribution in this space and would welcome the opportunity to have more dialogue, I guess, with us around how their role fits with this broader strategy. And I think the other component, and again sits with Manx Care's wider strategy, is how the voluntary and community sector play a really active role in any primary care at scale strategy. So it's just, I think it's a great piece of work, David, and I'm really grateful for all of your efforts and Anne-Marie's efforts to get this to this point. I think it's a great point from which we start having that real active dialogue with GPs. But I think those 3 points, in terms of looking for that clear alignment in the next iteration would be really helpful for us. Thank you.
Thanks, Teresa, and I too should have welcomed Anne-Marie. So Anne-Marie, consider yourself doubly welcome now. Oliver, did Teresa steal your point?
She did, kind of, yeah. But it was just really to say that, as the former leader for the integrated care programme within the DHSC and now Manx Care, although it's now under Sally within social care, it's worth saying that we've worked together really closely with David's team, with the primary care at scale team, and there is a very clear synergy between integrated care and the primary care at scale. So we worked quite closely to avoid any duplication of resources or duplication of service delivery, which I think we've achieved. And we've now got really clear linkages between the community integrated care offer and the primary care at scale. And I think together it can be a massive game changer for how we deliver care on the island. So.
Right, thank you, Oliver. That's a great way to sort of summarise. This is a very, very big deal indeed, or it plans to be a very big deal indeed, to substantially improve the care on the island from the patient point of view. And the board is not asked to make any decisions today, but you're asked to give approval in principle to the shape of this strategy. So again, I don't propose to have a formal vote on this, but if you could just sort of gently nod your heads if you're happy, or shake them vigorously if you're not, then I see lots of thumbs up and heads approved. So you have the approval in principle for that. So thank you very much to David and Anne-Marie.
Thank you.
Okay, moving on now to the second of our priorities. So the first one was about patient safety. The second one is about a positive working culture. So we've got an update from Anne. Anne, you're still on mute. Looks like Anne's PC is causing her some difficulty. Well, don't worry, we'll give you a moment. I'm sure you'll sort it. Okie doke. Right, well, do keep trying and shout if you do get it sorted out. I see Sally has put her hand up. Are you volunteering to take on this item, Sally?
I think I can take on quite a bit of this item in terms of the workforce and culture and development team have been working very closely with me within social care. And Anne, if you do get your sound, come on at any time. So they started some facilitated sessions for all staff across a range of venues last Monday. There was 2 sessions held last week, and I think there was 2 due this week. And this is really about giving staff a voice in a very, very safe space. As most will know, coming into social care, we've had lots of concerns raised, maybe around, you know, the culture not being where we would want it to be in terms of good working space for people. The sessions last week are also accompanied by some very short surveys, and I think the feedback in terms of attendance at the facilitated sessions and the surveys is positive. People do seem to be wanting to take that opportunity to help shape the culture that we're all going to work in going forward. These will be going on till the end of June, and then we look to plan together to look within social care how we actually move forward and start developing action plans. Alongside this, we've also looked at there's been an absence of flexible working within some areas within social care, and we've got a very short life working group together of a range of practitioners from a range of areas and a range of grades, etc., to look at, you know, how we will actually develop this and start developing in, you know, trust and integrity within the workplace as well. And the feedback is actually, certainly from last week, is that there's a real swell of optimism, hope, and that's one of the words that's been used, is hope, that the culture is actually, I think, actually been recognised, and that we're actually listening and we're actually doing something about it.
Thank you, Sally, for stepping in at no notice, and I think you have indeed given the key messages. I can see that Anne still has a technological problem, so she can't come in. Does anybody want to add? Oh, Teresa, you'd like to come in, please do.
Sorry, it was just to pick up a couple of other bits from the report, and just to confirm that the new Manx Care induction programme, which will be delivered in conjunction with the workforce and culture team, has now been signed off, and we start those from next month. I'm going to front as many as I possibly can. If not, a member of the executive team will step in on my behalf, and also we've prepared a staff handbook again, which another important development for us, which sort of almost makes a stand for what Manx Care feels is important, how we want to engage with our staff, the benefits of working for Manx Care, and hopefully staff who are onboarding into the organisation feel supported and welcomed. And I think there is still a lot of feedback coming through the letters, listen sessions, as well as the sort of targeted work which Sally has just spoken about. The general sessions are continuing, the themes are being collected, and I think as we go forward with this work, what we will bring to the People Committee and the board is what we have done. So it's important to listen and take on board. It's also important to demonstrate what you've done about the feedback you've heard, and so we'll start to share a lot of that with the board and the People Committee going forward.
Thank you for both of you sort of really helping to present that paper, and I'm sure Anne must be feeling very frustrated, but we'll try and get it sorted out for next time. Any questions or comments on this update? Nope. Okay, so I think we can accept that as a very good and encouraging report on the way the intended change to culture is beginning to have an impact already in the organisation. So thank you for that. Okay, the third of our initial main priorities is about improving financial health. So over to Jackie now, first of all, for the opening forecast.
Thank you very much. So you'll have seen the paper that was circulated, which is our initial forecast position for Manx Care. Following on from what we were saying earlier on about the level of data and the level of detail of data, we've kept this relatively high level for the board rather than delving into all of the detail underneath. But just to reassure the board that a lot of work has gone in at that detail level, which I'll talk about, to get us to the position that we have here. So just to give a bit of background and context, when Manx Care established itself or became live on the 1st of April, there were some significant concerns around funding pressures that the organisation faced. So obviously at its inception, Treasury invested a large sums of additional money into Manx Care's underlying budget to try to resolve some historical funding issues, particularly relating to legacy pay gaps. So we need to acknowledge that the baseline funding position begins as a much higher level of funding than historically has been the case. However, we identified probably around about 10.5 million worth of projects, business cases, and other things floating around the organisation that potentially Manx Care might be asked or expected to deliver. Which obviously was a fairly worrying situation to find ourselves in. There was also the fact that in order to meet our budget, we need to achieve 2.7 million of cost improvement targets in year one, which is ambitious. I'll talk about that later. And certainly there was also the element of the unknown. So we knew that there was a pressure around restoration and recovery. And Oliver has done some great work around creating a business case around that, which we'll talk about. But I need to emphasise that there's still an enormous amount of uncertainty around what's likely to come out over the coming months, and particularly as we start to investigate our services and understand some of the key challenges. Very often they will come with funding pressures associated with them. So whilst we have an opening forecast position that is absolutely live and constantly changing. So what I wanted to just explain here was sort of my logic and approach in arriving at that position, and then on a monthly basis we'll review that and we'll talk specifically more about how that forecast has moved. So how we started is obviously we started with our operational budget. And we have our 2.7 million, which is our cost saving target. And we have allocated a pot of money as a contingency fund. And the idea of that contingency fund is to try and insulate us from some of these unknown and unknowable funding pressures that we may face in the year. And then what we've done is the business case review group, which was established recently, has as its first priority reviewed those business cases and funding pressures that currently existed. We focused on, we categorised them into 3 categories. The first one was what we called committed, which is where effectively either it had been committed by a ministerial decision, or it was a statutory requirement or a legislative requirement, so that in effect this money was going to get spent whether we made the decision to do it or not. And so that was the first category. The second category then was uncommitted. So they represented a group of things where, as an organisation, we might wish to do these things, contingent upon funding. And then we categorised a number of items where we said we wouldn't do these things unless specific funding had been agreed to do that. What the big chunk of that was the NICE TA drugs. So I know that there's work going on with DHSC. They put forward a business case as part of the budget round for this financial year to fund those. That was rejected by Treasury. So now we're looking at re-looking at that issue. But unless Treasury funding is forthcoming, Manx Care won't progress that as an option. The business case review group has effectively reviewed all of the committed funding, and we've identified about 1.9 million of mitigations in year that we can set against those, so that limits the amount of what we're actually going to have to commit to. The other thing I've done is when we've seen the month 1 figures, we are overspent by 118k in month 1, and would anticipate that wouldn't continue. But I think as a prudent measure, we would have to make an assumption or a provision that might persist at some level throughout the rest of the year. So what we've done is assume that and factor that into the forecast. When it comes to the SIP savings, again, because of the challenges which I'll talk about later on the SIP issue, we've said, well, let's say we can achieve 1 million of SIP savings in the year. We need to maintain a contingency that allows us to make sure that we meet that 2.7 million target. Now, and all of that means that our forecast position is that we will be able to meet the SIP target, cover the currently forecasted overspend on our operational level, and meet those committed spending commitments within budget. But obviously there are significant other pressures that exist, which we will keep an eye on and formalise, verbalise and quantify as they come on stream. Sorry, I've just gotten distracted by some of the comments coming through. Oops.
Don't worry, Jackie. We're doing fine.
Sorry, I just lost the screen for a moment, but that's all right. So that's really just to talk you through how we've arrived at that position. But as I say, I have to caveat that by saying it's still a very fluid situation. The way it sits at the moment, we don't currently have sufficient contingency to cover any major funding pressures that might arise in the future. Obviously, if we overperform and we achieve more than our 1 million SIP, if we achieve our full 2.7 million SIP, then all of that money will be free then to reinvest in some of these funding pressures. So that's kind of where we're at the moment. And as I say, as we review our services, we will find things that we're going to have to maybe make decisions about, stopping some things to do other things, or look at alternative funding options for those sorts of things. And the other thing on the back of that is that a lot of this work will help us to inform what the budget bid for the next financial year will be, because that work has begun already. So it's really important that we try and root out as many of these pressures and risks as we can, as soon as we can, so that when we're doing our funding bids for next year, we can be a little bit more confident that what we're asking for is likely to cover what it is our aspirations are for next year. So happy to take any questions or comments on that.
Okay, well, Jackie, I think obviously this was gone through in great detail in the Finance Committee, so I don't think there will be that many questions. And we're just beginning to get a little bit tight for time in terms of allowing for the questions that have been submitted. So can I just ask you to go straight on to the next item, the CIP governance, and to cover that relatively briefly, please?
No problem. So just a quick update. As I say, you'll see the detail around the proposed governance around the SIP programme. So it's really important that we have good, effective governance around that to make sure that we don't fall into the traps we've done previously, where we set up these programmes and then we don't ensure that they actually deliver, and we don't measure what they've delivered and learn from that. In terms of progress, all of the deep dives with each of the individual areas highlighted have now completed. So now we're moving into the phase where we're gathering all of that information, all of that feedback to create that detailed action plan, which will actually give us a really much clearer picture of what we actually think is achievable in year one financially. But it's also important to make the point, and we talked about it earlier, that SIP is not just about taking money out. It's not just about the money. And a lot of the conversations we were having in these deep dives were, absolutely, we have a target to meet and we need to release cash in order to reinvest it in other areas. But also an acknowledgement that a lot of the work we do in year one, there are quick wins we need to do to release cash. But there's also a lot of work that we need to do to lay the groundwork for the savings in years 2 and 3. Because if we don't begin that work, then we won't meet the targets further on down the year. And, it's about improving quality and service delivery and patient safety. And, the financial, if we operate efficiently as a service, then the financial efficiencies will flow out of that. So it's important that we make sure that we remember that it's not just about stripping money out of the service, and any money that we do save is immediately reinvested into doing some of the other key things that we really want to be doing.
Right, thanks, Jackie. So I'm just going to give anybody the opportunity to ask questions on either of those two documents. As I said, we have been through them fairly extensively in the Finance Committee, so I suspect that's why there aren't any questions coming in. Right, okay, thank you for that update then. So in terms of agenda item number 38, any other business? Nobody has given me any other business, so we can pass on from that one. And then we've got a section of the board meeting which we will devote to questions from the public. And as I said right at the start, because of the nature of this meeting, we've had to take those questions in advance, and we have two. So the first one is to Teresa, and it's a nice simple question. What has the executive team achieved since Manx Care came into being on the 1st of April?
Okay, thank you, Chair. And I hope this sort of board meeting and some of the contents of some of the papers have identified what the executive team have been busy, as well as the non-exec supporting over the last couple of months. But I think just to summarise, we have made all of the senior appointments now, so we've established the executive team in full, and also the care group structures, so the triumvirate structures and leadership arrangements for each of the new care groups which are leading Manx Care. We have our governance structures from ward to board or ward to service line, which is really, really important. So as well as the board subcommittees, which have now met twice in April and in May, we've now got the operational structures and governance in place, which I think is really, really important. They are embedded and established and are being used. That ensures we are delivering and can monitor delivery against the ROF, and also can hold our care groups to account. We've had the first 4 of the performance and accountability reviews, and the further 4 are scheduled for next week. I think just in terms of our key priorities around patient safety, improving culture and financial sustainability, I think the papers here demonstrate we've got clear focus on that. So really pleased to see the theatre improvement work started. really pleased that we are, as an executive team, getting out and about into our services, understanding the quality of those services, which mitigates in part against the lack of data we sometimes have. So really, really important we're able to see for ourselves the quality and get the feedback from those services. We are in listening mode with our staff, and that has continued. And I think, if I just point to Sally's area alone, a huge amount of work that Sally as an executive is leading in terms of that staff engagement piece, which probably wasn't anticipated when Sally initially started, but incredibly important, and important that we support that piece of work to ensure we are developing the right culture, and we are supporting staff to raise concerns when they do feel there are concerns to be addressed. I think finally, a really important point, and I know it's something the public are really concerned about, is the length of our waiting lists. And really important that through the executive team, and particularly with Oliver leading, we are developing those plans at specialty level to respond to some of the waiting time concerns that we have, both in terms of planned care, routine care, but also in terms of cancer care. And a really important piece of work is to have our own internal plans, but also create that longer term response in terms of a business case, which we have now shared with Department of Health and Social Care colleagues, to be able to articulate how we would respond quicker to addressing the waiting list challenges that we face as Manx Care. So that is just a very brief summary, but our visibility, our focus on quality and safety, our focus on culture, and getting our financial plans in place and our good governance across the organisation is where we have been prioritising our efforts over the last 2 months.
That's an excellent summary, Teresa. And you made the point yourself that really the content of the entire board meeting today has been about what has been achieved so far. So thank you for that. The second question is probably mostly for Sri. And the question is, what have the consultants done by way of using telemedicine during COVID?
Right. We know that COVID has caused significant pressures on the waiting list, which we have already alluded to, not just to the inpatient stuff, but to the outpatients itself. Through our outpatient transformation teams, what we've done is, over the course of last year, we have consultants have each individual specialty have their own clinical pathways to set up to address the need of waiting patients on the outpatient pathway, which means that they are able to prioritize the patients who need to be seen face to face. They also mean that the patients who actually need urgent appointments will be given that way, but also not just about then, but it is also going in future, how we actually, transform our way of reaching out for the public of, public of Isle of Man, how we actually address those problems. So consultants, all specialties right across the spectrum have devised individual clinical pathways to address the needs of the patients with the island. Thank you.
Excellent. Thank you very much, Sri. Okay, so there are no other questions from the public at this stage, so I'll go on to the last item, which is feedback on the meeting effectiveness. What I would say is that if there are people watching this in the public, I would welcome any feedback, either to me personally or via the Board Secretary, John Middleton. We've made a series of judgments about how best we can manage this under the circumstances, and that's what's been offered today, but this is just the first of many, many meetings, and we're more than happy to evolve the processes and approaches that we use, and it would be really good to get any feedback from anybody about that at all. I think all has gone well apart from poor Anne, who got strangled by her technology temporarily, but thankfully is now back on, and you'll certainly get plenty of opportunity next time around, Anne, to have your say. So I think at that point I will draw the meeting to an end. Thank you Thank everybody for their attendance and contributions to the meeting, and the next public meeting is on the 27th of July. Thank you, everybody.